A 41-year-old presents with a 12-hour history of acute onset dizziness, slurred speech, expressive dysphasia, and right-sided weakness, with a history of stroke 6 months ago. I am showing you sagittal, axial, and coronal CT angiograms of the neck. Describe the findings.
Right, so the sagittal CT angiogram reformatted image demonstrates a smooth, triangular, shelf-like filling defect arising from the posterior wall of the left internal carotid artery. This filling defect is located just above the level of the carotid bifurcation in the proximal internal carotid artery bulb. On the coronal CTA reformat, this thin, linear filling defect projects into the vascular lumen but does not cause significant stenosis. The axial CTA view confirms the presence of a posterior intimal shelf with contrast filling the lumen both anterior and distal to the web. The other visualized cervical vessels are of normal caliber, patent, and show no signs of fibromuscular dysplasia or atherosclerosis.
What is the diagnosis, and what is the differential diagnosis for this carotid filling defect?
The diagnosis is a left internal carotid artery web, which represents a rare but important etiology of ischemic stroke in young patients. The differential diagnosis includes a carotid artery dissection and a focal atherosclerotic plaque. A carotid dissection typically presents with a longer segment of narrowing, located more distally in the cervical segment, and exhibits a classic flame-shaped tapering or double lumen on sagittal views. An atherosclerotic plaque would show more irregular borders, eccentric calcification, and occur in older patients with typical cardiovascular risk factors.
Explain the pathology, clinical significance, and mechanism of stroke associated with carotid webs.
A carotid web is a rare intimal variant of fibromuscular dysplasia characterized by a thin shelf of fibrous connective tissue in the posterior intima. Unlike typical fibromuscular dysplasia, which shows a string of beads appearance in the distal internal carotid artery, a carotid web is localized to the carotid bulb. The web acts as a mechanical barrier to normal flow, creating a pocket of blood stasis and turbulence just distal to the shelf. This stasis promotes thrombus formation on the venous side of the web, leading to recurrent cerebral emboli and stroke. It must be strongly considered in young patients under 50 who present with recurrent cryptogenic stroke or transient ischemic attacks.
Why are carotid webs often missed, and what is the role of digital subtraction angiography?
Carotid webs are notoriously difficult to appreciate on standard axial imaging because they are thin and run parallel to the axial plane. They are much better identified on high-resolution sagittal and coronal multiplanar reformats, which highlight the shelf-like structure. Although digital subtraction angiography remains the gold standard, demonstrating early-phase filling defects and venous phase contrast pooling, CTA is the primary diagnostic tool due to its non-invasive nature. Additionally, because carotid webs can occasionally be bilateral, careful evaluation of the contralateral internal carotid artery is always indicated.
Discuss the appropriate further investigations and therapeutic options for this patient and how you would manage them as a radiologist.
Further imaging should include a brain MRI with diffusion-weighted imaging and FLAIR to define the vascular territory of any acute or chronic infarctions. Given the history of recurrent stroke, this patient is at high risk for further ischemic events and must be immediately referred to the stroke team. Therapeutic options include medical management with antiplatelet or antithrombotic therapy, or surgical intervention with carotid endarterectomy or endovascular carotid stenting. As a radiologist, I would communicate this finding immediately to the clinician, highlighting the web as the likely source of thromboembolism.